Thank you, thank you. So here we start again on the sensory disorders. So I think that I was just telling, starting a minute ago, and I was saying that my primary background is in the NICU, not the NICU, but the PICU. And we would have patients come in all the time, babies come in that were in DHS custody. And I remember one specific little baby that was there for 5 months. She had a myriad of problems. She had a syndrome that had about 21 anomalies associated with it. One of them was a heart condition. And so she had several heart surgeries. But she had been in DHS custody since birth. And basically, she was ventilator dependent. And so she was in a bed all the time. And basically what we did was turn and reposition her every 2 hours. But she didn't have anybody cuddling her. She didn't have anybody talking to her. She was legally blind. We thought she was totally blind at the time. It just, she just didn't have any stimulus at all. And so of course, this happens all the time in the PICU. You get a nurse with a soft heart. One of my friends adopted her and took her home. And I would go over there all the time to kind of watch how she developed and how my friend would deal with her. And I got to tell you, it was the funniest thing because she would, she had such an aversion to touch and to taste anything in her mouth. She had a G-tube, so she had only been fed formula her whole life and through a G-tube, so she rarely had anything in her mouth. But just putting oatmeal on her high chair and putting her hand in the oatmeal to touch it, she would start gagging. It was the funniest thing. I loved it. And no, I mean, not to see her gag and be in discomfort, but she just didn't like that. And it took a while for her to get used to being held. She didn't necessarily like certain fabric on her skin. It was just interesting that when you don't have stimulus there, that those senses don't develop very well. And so we are going to look at today specific senses. Now, because we are dealing with a sensory system, a lot of the lecture today is going to be on the or over the comprehensive health assessment, neurological and assessment. So it's going to be a lot of the review, but don't think that since you've had your comprehensive pass off and that we've had a couple of neuro assessments or neural lectures and tested that we're done. We're not done. So the information that is kind of redundant today that you've had before will be on the test. So here are our objectives for the day. We're going to identify components of the face and the eyes and the ears and the nose and the mouth assessment. We're going to compare the clinical manifestations and medical management of patients experiencing cataracts and glaucoma. We are going to identify patient care following cataract surgery, and we specifically use cataract surgery as our template for all optic surgeries. So there's principles for nursing interventions that are utilized for any kind of eye surgery. We will identify nursing interventions that assist patients with reduced vision, identify nursing interventions that assist patients with partial or total hearing loss. And we have also included identified nursing interventions that assist patients with partial or total loss of sense of taste and smell. And there will, even though that is not an objective, there will be a test question on that specifically what's covered in the student presentation. All right, so let's begin with where we started. Vision involves the focusing of light rays on the retina and then the transmission of subsequent nerve impulses to the visual areas of the brain. So again, we have light coming through the iris there and then through to the optic nerve, and then the optic nerve goes on into the deeper brain. So here is a picture of the eyeball, and you don't necessarily need to know everything about this, but there's some points that I think will help you remember some future content in this lecture. So first of all, let's look at the outer aspect of the eye. So let's begin with the sclera here. We're going to talk about the sclera somewhat today, and we also talked about the sclera yesterday as far as assessment was concerned with the skin, hair, and nails, that we look to the coloration of the sclera. Now, the sclera is this white portion of the eyeball, and it migrates into the cornea, which is a clear portion, and then it goes back to being white in the sclera. So it's one continuous piece here. And then we have the iris, and then we have the pupil. And then behind the pupil, I think everybody kind of confuses the cornea with being a lens. It is, in fact, not. The lens is literally behind the pupil. And this is where they make a little slit for cataract surgery, and they will lift the lens out from behind the pupil here. And then we have, this is the optic nerve right here. This is the retina, this inner lining here that just is the inner aspect of the eyeball itself. The aqueous humor is right here on the inside. That is a jelly-like material that keeps the eyeball in its shape. And then you have the muscles that, of course, are innervated by cranial nerves. Okay, here's another view of it, a cross-section of it. And again, you'll see this lens back here that is behind the cornea and the pupil. And then the aqueous, oh, they have the vitreous humor here. I thought it was aqueous humor. It is aqueous. I don't know. Anyway, the optic nerve and then the retina is right back in here. All right, and the retina often is going to be what gives you your red reflex. All right, so just to be clear again, iris, pupil, sclera. All right, so if we were sitting in class, I used to have this, have the students do this, is have them take a second and look at each other's eyeballs and see what the sclera is doing. And there's a lot that can tell the healthcare provider if they have something going on with the conjunctiva. So if you look into your patient's eyes and see these red eyes here, then it could be several different things. It could be allergies. It could be a late night studying for an exam. It could be computer fatigue from looking at the computer too long. So when you see that this is an abnormal finding, and you want to question your patient to see, what he or she has been doing that would elicit such a response. We talked about jaundice yesterday, which is very indicative of hepatic disease or liver disease. And so we talked about the sclera being yellow, but the best place to assess it to make sure you're looking at the sclera being yellow is right up here by the iris. And over here sometimes, and the reason why we say assess here is because over here, a lot of times, heavier people or people that eat a lot of fat will have these little jelly-like globules of fat right here in the corner of their eyes, and sometimes they have a yellow tint to them. Excessive tearing, again, this can be from allergies. My daughter was in an accident when she was 13, and her cranial nerve 7 was affected, and so when they went in, she had a bone fragment through the nerve. It didn't sever the nerve, but when they went in to find it, the surgeon cut the nerve that stimulates tearing in that side of her face, because he said basically that has become a stupid nerve because of the effect of the damage to the cranial nerve. And so he said it will water when she's not expected to water, and it will tear when it's not expected to tear, and it will not tear when she's crying. And so she has a very dry eye on that side of her face. And when she cries, the left side of her face gets real red and blotchy. You know how it is when you're crying. And that side of her face doesn't. Very interesting. Okay. Another condition that you might see when you're looking into your patient's eyes is bulging eyes. Does anybody know what nursing school too? I just looked down McKenna. So does anybody know what the technical medical term is for bulging eyes? Exophthalmos. You remember it's the long one. Exophthalmos. Yes, say it fast if you want. I just say bulging eyes. Okay, this is very much associated with Graves' disease. And so, again, when you see this with your patient, you might ask if they've ever been diagnosed or been tested for Graves' disease, which is a thyroid, a hyperthyroidism issue. Okay, so then we have ptosis, which is a drooping eye. This is often associated with myasthenia gravis, as we learned from the last lecture. So again, when you see this on a patient, you want to investigate further. That's really what a nurse's job is to investigate. Graves, yes. There you go. Thank you, Amy, for saying exophthalmos. Exophthalmos. Say it fast. Everybody say it together. Exophthalmos. Okay. Excellent, Amy and Braden. Okay, so back to myasthenia gravis and nursing. What it really is that you become a detective. It's not that you just do your baseline assessment and you document. When you find an abnormal finding, you've got to question. You've got to look further. You've got to see if there are any other signs and symptoms. I think we mentioned that yesterday with clubbing, is that, oh, you see clubbing of the nails. Now we got to look for further signs of hypoxia. You've got to keep looking to see if you can see if there's any physical reason, or if the patient themselves know that there is a reason for the abnormal finding. Okay, so now we get into the old comprehensive health assessment that we all loved learning, but you'll be surprised. They're in education. There's theories that suggest that to put anything from short-term memory into long-term memory requires hearing it, seeing it 3 times, a minimum of 3 times. So when we look over some of these things, you're going to find these assessments were part of the comprehensive health assessment, and that's exactly what we're trying to do, is commit this information to long-term memory. So the first thing we're going to look at is visual acuity. Of course, this involves the gross visual screening, and that you had your patient during that assessment read something, and then you also had them look at the Snellen eye chart. So when we are having the people read something, what exactly are we looking for?
How close or far away they hold it?
Exactly. We want to notice if they're having to hold the paper up real close. Another thing, I don't know if this was mentioned in Wendy's teaching of this, but sometimes you'll see them tilt their eye or tilt their head to read a paper that was originally directly in front of them. And the purpose of this is that some elderly people are starting to have macular degeneration, where they are starting to lose their sight. They have a pinpoint in the middle of their visual field where it's all black. And so they only have this peripheral vision. So they have to kind of tilt their head to do any kind of reading. But also, if they have to hold the paper way far out as well. So we need to make sure that another thing that it allows us to know is whether or not the person can read or not. If they look at it and they say, I can't read it, then we need to probe a little farther and see if they are able to read. Actually, people that are older, that have adapted to not reading, they oftentimes get information in another way. But if they cannot read the printed material, we want to go directly into the Snellen eye chart. And if they don't know the name of the letters, then you can ask them to describe what they're seeing. So the Snellen eye chart, as you know, has an alphabetical letters that graduate in size. Now, remind me, what does 20/20 mean? 20/20 vision. At 20 feet away, you read what most people do at 20 feet. That's right. We don't like to say normal vision, but it is what the majority of people at 20 feet are able to read the letters that are on the line 20 accurately. Okay, so that is what I put in parentheses normal vision is. So what the examiner does is mark 20 feet on the floor, and then the examiner asks the patient to cover one eye and read out loud an indicated line of letters. But do they do this with correction or without correction? Are they wearing their glasses or do they not wear their glasses? With, exactly, Ashley. So the next line on the chart is 2013. So what does that mean? So actually, Alina's got it, is that the majority of people would be standing. It's kind of backwards here. The majority of people with standing at 13 feet would be able to read the same line on the chart. But the person being examined has better vision than the majority of persons. So the person that is standing at 20 feet can read what the majority of people see at 13. So the top number, remember that the person being tested is always standing at 20 feet. So 20 feet is always going to be the top person or top number and what the person is seeing. And so the majority of people is the bottom number. And so this person has better vision because they can read at 20 feet what people at 13 feet are reading. So make sure you understand that. There's some questions on the test about that. So make sure you understand the readings on the Snellen and eye chart. So when a person gets 27, so 70, so most people can read at 70 feet what you can read at 20 feet, then that means that you are have low vision, but 20 over 200 is basically you are legally blind. You can't even read the big E. So, and that's with glasses. So you have to understand that there's considered low vision, and then there's 20 over 200 is legally blind. All right. So let's talk a little bit about visual fields testing. So this is basically about peripheral vision. It tests the person's ability to see objects peripherally while the eye is fixed or kept in one position. And I have to tell you this too, without context, my boyfriend is one of his eyes is 20. Oh my gosh. Yeah. He's like really not seeing very well with one eye. Crazy, crazy, crazy. My dad's vision was 20 over 400 too. Ugh. All right, so the thing about peripheral testing, have you ever seen older people that have these really bulky eyelids? They're just droopy. They kind of, the eyelid itself has lost its tension in the tendons that hold the eyelid open. And so the eyelid kind of hangs over the eye. Well, that totally obstructs your peripheral vision. And so insurance will pay for you to have that eyelid kind of fixed if you do not have normal peripheral vision. So that's really the test that determines whether or not that the insurance will pay for that operation. So you all know how this is. This is testing the visual field by confrontation. You're standing in front of the person, but all of you during your comprehensive health assessment stood behind the person. Okay, this is your extraocular movement, and remember that there are 3 cranial nerves that control this direction. Depending on which direction you're looking is depending which cranial nerve is working. Okay, I think we're all pretty familiar with PERLA. PERLA is pupils are equal, round, reactive to light, and accommodation. I'm sure you're very familiar with direct and consensual, and we document it as being brisk, sluggish, or absent. So let's see, accommodation is the ability of the pupil to respond to near and far distances. So, if a person comes in to my office now with this super lighting that's really, really bright, it's kind of hard sometimes to shine a light into the pupil because it's already light. So the pupil is pretty much constricted already. So what can you do to help a person or help the healthcare provider look and determine direct or consensual reactions with a well-lit room? What are you going to do? Oh, might help if I scroll down and look at the messages here. Turn off the lights. Exactly, Megan. Dim the lights in the room and then go with your pin light to look directly into the. All right, so cranial nerves, optic, the ocular motor is nerve number 3. It deals with extraocular movement and the reaction to light and accommodation. And then cranial nerve 4 is it directs the movement of the eyeball. And then abducens nerve number 6, of course, talks about lateral movement. All right, so now we're talking about looking at the red reflex when you use an ophthalmoscope. So what is the correct way to use an ophthalmoscope? Megan is typing furiously. Oh, I was reading the last one. Turn off the lights. What I'm looking for, let's see. Right hand, right side, exactly. And don't forget left hand, left side. So don't use the right. And yes, you use your little pinky so that you don't, because you have to get pretty dang close to get in and see this red reflex. And so you don't want to be smashing them in the eye with the ophthalmoscope. So have your little pinky extended to put some distance between you and their face. But we're looking for the red reflex. So we're also looking for broken vessels in here. A lot of times, and don't blind mark like I did. There you go, Kim. No judgment here. No judgment between any of us. This is a safe zone. Okay. So with broken vessels here, you're going to see this with shaken baby syndrome. You're going to have you're going to see that the retina has been somewhat detached. You'll also see some damage done in these vessels for a person that has diabetes. So there's a lot that these vessels can tell you. This is a macula right here. All right, so I think that covers it for the eyes. Let's move on to the assessment of the ear. So we have here the outer ear. This is the anatomy of the ear, the external ear. And we're going to start with the anatomical structures of the outer ear. We have the pinna, which is right here. And then we have the external auditory canal right in here. And then we have the tympanic membrane. What color is this supposed to be? Not really a white, it's a pearly, it's a pearly gray is what it is. It should be kind of a pearly gray there. And when you shine light into it with the otoscope or the otoscope, then you're going to see this light reflect back to you, and that will be white. If the eardrum is not intact, or if it's swollen or if it's inflamed or something like that, that light reflex is going to be lost, just so you know. So then we go to the middle ear here. Now here is something that nursing students sometimes get confused on. When I use the term otitis media, I am talking about infection beyond the tympanic membrane. Otitis externa is right in here. And oftentimes, because you'll have the eustachian tube that has not the eustachian tube, but the canal itself can be very inflamed for some type of reason. So that's otitis externa in here. So just recognize when you see questions or when you are documenting, otitis media is beyond that. That's when you have fluid behind the ear, where the eustachian tube comes up behind the ear, and because there's infection going on, then there's fluid behind here, and you'll often see this tympanic membrane bulging. Sometimes you can even look and see the level of fluid behind the ear. But we refer to this in here if there's any problems with vertigo, with balance, because of these little canals right in here that all contain fluid. There's 3 of them, and they all go in different directions. And it's like there's 3D. That allows us 3D perception of ourselves, which I just think is such a miracle. But anyway, if there's infection going on here or the fluid level is low for whatever reason, then you can have vertigo problems. But recognize when we're saying otitis externa or otitis media. And that often gets confused in the healthcare world, but when you're documenting, recognize what you're doing. So these semicircle canals right here, as I said earlier, are responsible for balance, and any disruption here can cause vertigo. Okay, and the eustachian tube itself is connected to the nose. Okay, so we talked about the pinna. Let's go back for just a minute. Right here is, you can't really see it. This is the little area that comes down outside the ear. I think that I have a slide on the next slide, I think. Yes, better. So you see here the external portion of the ear. Now, remember, this is all made of cartilage. This pinna and this outer area here is all made of cartilage. This is made of cartilage. And so, again, this does not regenerate, as Brad was saying yesterday in the lecture, that if it gets burned, it just kind of withers up and crumbles away. Okay, this is the meatus that I was talking about. This is the tragus. This is the lobe. You should be familiar with those. All right, so when we are assessing the outer ear, we're looking for placement, we're looking for size, shape, symmetry, and the mastoid area, which is right in here. So if there's any swelling that goes on, oh my gosh, it's so tender. It is so tender. What do you think is wrong with this ear? What do you think is happening here with this ear? Infection. It's infection. It's actually infection from a piercing. The piercing gone wrong. You see the little hole up here. So massive infection. And don't you think that hurts a little bit? Yes, it does. It's very much an abscess. Okay. So when we're talking about the auditory nerve number 8, it's not the auditory nerve. I should reprint that. That's basically the acoustic nerve, number 8, and it also has to do not only with hearing, but with balance as well. And then we have the ear canal. I think we've already talked about that, but you know, you may not be able to see this tympanic membrane. And the reason could be that there is excessive cerumen. So this person has earwax that is occluding the view. The earwax doesn't have to be a nice golden color. It can be black. But it is totally filled the canal, and you cannot see the tympanic membrane. Also, there may be a lesion. Sometimes people will try to get in there and clean out their ears with a bobby pin or something like that, scraping the external auditory canal and therefore having it a little bit inflamed. Foreign bodies like beans, or if there's any kind of drainage that is coming from a pierced or a perforated eardrum. All right, so we've already talked about the reflex with that. Okay. We're moving on to the nose. Okay, so with the nose, what is the function of the upper airway? This should come from your basic anatomy and physiology class. What is the function of this nose here? Filter, exactly. Moisten, exactly. Warm, exactly. Yep, you're getting, it is considered the first defense for the respiratory system itself. So all those things, remember that, for what the purpose of that is. What would be an abnormal finding that's commonly found with performing an internal assessment of the nose or the nares? Deviated septum, definitely, definitely. And some people don't even realize that they have one. They just know that one side of their nose is always congested. What else? What about pallor? And there you go, Amy. What about pallor of the membranes here and watery drainage? What is that going to indicate? A cold, a cold inflammation of the mucosa that narrows those nares is indicative of a cold. A watery drainage is always going to indicate that there is some kind of allergy going on. What kind of drainage are you going to see with a cold? Thick, yellow, creamy, yeah. Nice, disgusting stuff. All right, so when we are examining the nose, what we're looking for is asymmetry of the nose has been broken and is now not in the middle of the face. Is there any inflammation or other deformity that is visual? When we look inside the nares, we're looking for the mucosa. First of all, we want to make sure that it's patent, and that would not be patent if there was a deviated septum. We're looking at the color of it. We're looking at the lesions, swelling, or bleeding. And then we always want to look and ask if they have any discharge and what color is it. Clear and watery, again, indicates allergies, and infection indicates yellowish or green. Okay, so olfactory nerve number one, again, is smell. Did you know that one of the first signs and symptoms of Alzheimer's is the loss of smell? But how many times have you gone to the doctor and had them test your sense of smell? Never in my entire life have I had that happen. So many times that is definitely missed with Alzheimer's. All right, let's go to the sinuses here. So the sinuses themselves are cavities. So when palpating the sinuses, the nurse should feel a very firm pressure when they're feeling it. So these are the frontal sinuses right up here. And usually if it's real tender when you press on this, it means that there's a sinus headaches. And sinus headaches are typically viral, so there's no antibiotics that you can really do to make that heal. And they won't treat for any kind of infection unless the person has had this going on for more than 10 days. These are the ethmoid sinuses right here. And if an ethmoid sinus is infected, the pain will occur between and behind the eyes. Oh, have we felt that before? Oh, yes, I think I have. But then with the maxillary sinuses, if that's infected, the patient will have pain over the cheek and above the teeth. Sometimes you feel like it's coming down into your teeth. It's, migrating, but it starts out, the pain is going to be behind the cheek. All right, so now we're going into the mouth, and we look in the mouth. First, we see the uvula back here. That is not to be confused with vulva. I'm just saying. So this is we want to look to make sure that it's midline. We're going to make them say ah and see if it moves at all. The soft palate, is the soft palate in the front or is the soft palate in the back? Back. That's right. Because when you eat, the soft palate moves up a little bit to occlude the nasal cavities there. Then you see the tonsils back here. These are way back in here. And then the posterior pharynx. And the thing about it is sometimes that will be bright red. And you think, oh, they've got a sore throat. But actually that's because nasal drainage is coming back behind there. And it just irritating the heck out of that back throat. So recognize what color it is and document accordingly. Okay, so now we're looking at trigeminal nerve number 5, which is sensory for light touch and motor. This is when you clench the jaw. Cranial nerve number 7, we've talked about a little bit about, and it is the anterior 2/3 taste of the tongue. And then we want to raise the eyebrow, smile, puff out your cheeks, frown, all those different facial movements. And also, when you're thinking about that, we're talking about the movement themselves, but it also provides tone to the musculature of the face. And so if you see that a patient has a flat affect on one side of their face, there's no muscle tone there, it kind of hangs and doesn't have tone that gives it a firmness, or doesn't have a contour to the face, then you can suspect that cranial nerve 7 has been affected. Okay, cranial nerve 9 is the glossopharyngeal. That talks about taste, and it talks about sensory impulses from the tongue and the pharynx. Cranial nerve 10 is responsible for swallowing, and cranial nerve 12 is responsible for tongue movement. All right, so we have gotten through the assessment portion of the sensory system. So we are going to take a 10-minute break and come back at 9 o'clock. Be there, be square. Okay, we're back. Yay! I don't know if everybody came back, but I came back. And that's all that really matters, doesn't it? All right, so we're going to begin with talking about different eye disorders, and we're going to begin with talking about refractory disorders. So refraction refers to the bending of light rays as they enter the eye, and you can see that here on this little fabulous picture. These are the light rays coming in, and then where those light rays end up is the most important thing. So ametropia is a term that is used to describe any refractive error in which the eye is unable to bring light rays emanating from an object viewed from a distance into clear focus in the retina. So whatever happens, it could be blurry vision, it could be myopia, it can be farsightedness, it just whatever. Any kind of problem whatsoever. So myopia is caused by light rays that focus in front of the retina. So right here, this is going to be nearsightedness. Notice that this light rays don't touch the retina. at all. And so that is what is referred to as nearsightedness. Farsightedness is where, down here, this is farsightedness, where the light rays go beyond the retina. And then an astigmatism right here, where there's unequal curvatures in the shape of the cornea right in here. It's warped kind of, so there's not a smooth surface. So you have light rays that enter and go different distances. And so you end up with very blurred vision. And then hyperopia is farsightedness. We've already talked about that over here. And then presbyopia is also known as aging sight. This is just where their visual acuity is affected. There is also a term called strabismus. Does anybody know what that is? I brought from home. So Jody just was knocking on my door wanting to know what is happening. And it's like, okay, I brought my own home computer to make it work today. All right, strabismus back. It's not lazy eye, it is crossed eyes. And one eye deviates from a fixed image, and it can cause a permanent vision loss, but it's usually found in children and can be corrected if they strengthen the muscles in one eye. The good news about refractory errors is that we have glasses today with correctable lenses that can help the patient see 20/20. Okay, so let's talk about eye safety and basically how we can prevent injuries here. So we have two different kinds of injuries. We have foreign bodies and we have chemicals. So have any of you ever had a piece of dust or sand in the eye? A hair? How irritating is it? It's like so maximum. You cannot think about anything that is else but getting that foreign body removed. And it's because the cornea is a protective outer layer in front of the eye, and it is incredibly sensitive, and it's intentionally extremely sensitive. You don't want to have something over the cornea that can damage it. So foreign bodies will produce an incredible sensitivity and pain when the eyeball or the eyelid moves. And what usually happens is that the eye will tear excessively in hopes that that extra fluid will move that foreign body to the outer aspect of the eye. The safest removal of any foreign body is to flush it with sterile saline or water, and you want to flush it from the sclera across the cornea. If the object is embedded with dirt in the eyelid or something like that, you want to have the patient look upward and inspect and remove the object. Most of the time, these objects, these foreign objects, are superficial, but they are so irritating that the person will just, like I said, that's the only thing they're going to focus on until the object is removed because it's so painful. Another potential cause for injury with the eye are chemical burns. So when the eye has contact with either acids or alkaline substances, you really have to consider it an emergent situation, and you have to treat it immediately to prevent any vision loss. The burn severity to the eyeball will depend upon the agent that's involved and the length of time of the exposure and the depth of penetration. So what is interesting here is that alkaline substances usually cause more severe damage than acids. And the person's going to end up with decreased vision. They will have either moderate or severe pain and definitely decreased vision. And with severe cases, the alkali exposure, the eye will appear white, as you can see in this picture here, because of the ischemia to the conjunctiva and this scleral vessels. Interesting. I mean, you see this on TV all the time, but it actually is a situation. Okay, here, I don't know if you can see this or not, but this is a cornea abrasion. And corneal abrasions typically have a normal visual acuity, and they have a normal pupillary response, and the defect is often required to be seen with fluorescent staining. So the pain sensation may be there for several hours because, as we said earlier, the cornea is so extremely sensitive. The thing about it is that there's going to be conjunctival redness. There will be a hyperphotosensitivity. There will be decreased visual acuity. There will be erythema. And there might be itching, severe itchings. The good news about the cornea is that it regenerates itself and heals very well. So if you have an abrasion that hurts like crazy, then usually it will heal within 24 to 48 hours. Just move this over a little. Oh, I wish I could, but I can't. Anyway. All right, so let's talk a little bit about lacerations or penetrating injuries right now. So penetrating wound symptoms depend on the area of the eye that was involved. In the injury, it is the most serious type of injury to the eye, and anything penetrating the aqueous humor or the vitreous humor inside the eyeballs is going to allow that fluid to ooze out of the eyeball, and the eyeball will start losing its shape. It makes it very difficult for the ophthalmologist to fix. So the main intervention for the nurse is not to let the laceration or the penetration get any worse. You never, ever, ever remove a penetrating object from anywhere in the eye. And usually what we'll do is take a paper cup and put it over the penetrating object and tape it down to the face so that there's no pressure on whatever's penetrating the eye. And it keeps the eye covered and protected from further injury. But here's what a lot of people fail to do, and that is to cover the non-affected eye as well. You don't have to cover it, not necessarily with a cup, but you don't want that eye wandering because of consensual movement of both eyes. So you put an eye patch or you tape that eye closed until the patient can get the emergent treatment that they need. And you do need to get the person to the emergency room as soon as possible because there is such a high risk for infection there and for further damage. Okay, why is this way down here? Because you know why? You're not getting to read all this. So I hope you have your PowerPoints pulled up with Canvas so that you can see the entire slide, because I don't know why it slides like this after we load it into Canvas. All right, so emergencies to the eye. I mean, when an eye has been injured and there has been an emergency or some kind of trauma to the eye needs to be assessed immediately. And you need to see exactly the best that you can what is going on. Prevention is the best policy. So in order to avoid any eye injury and to protect the patient's vision, you have to educate your patients. So tell them to wear protective goggles when performing tasks that are potentially hazardous to the eye. And it doesn't have to be strictly an occupational hazard. You can be out mowing your yard, or you can be out edging your yard, anything like that. Wear protective goggles. Follow the manufacturer's recommendation too, for use of the goggles, but also you want to I don't know how to say this, but have side covers on. Most people think of goggles as just covering the front of the eyes. No, we need it to go clear around to protect all sides of the eye. Also, how many of you out there wear contact lenses? I do. Oh, maybe that's a HIPAA violation for me to ask that. But anyway, thing about it is when you got those contact lenses, weren't you instructed and educated on how to wear them and what protective mechanisms you need to use with contact lenses? Of course, you need to keep them clean. You need to follow the manufacturer's recommendations for wearing the contact lenses. And you need to know, get some instruction on wearing them when you're swimming or when you're sleeping. They do have contact lenses. I don't wear them, so my understanding is that you can wear them for multiple days at a time. Is that true? Anybody? Yes. Okay. So it's there. However, that being said, how many of you have lost a contact lens on your eyeball somewhere? I know. It's horrible. Horrible, because you can't get to it. You know it's there. You know you haven't taken it out, but you can't find it. It's not where you left it. So again, this has the potential for having infection or having greater risk to damage to the eye. So be sure to follow and instruct your patients to follow the manufacturer's instructions with regard to wearing the contact lens. Hold on for a minute. Somebody's at my door. Just a minute. Okay, I'm back. Sorry about that. Had to take care of that. All right, so we got that taken care of. Let's keep going on. All right. All right, so let's talk about glaucoma for just a minute. As you know, this deals with one of the objectives. And I'm going to stop here for a minute because usually I do this on the first lecture. And because of all the chaos that's gone on, I haven't done this. I'm going to bring up on my screen this sensory PowerPoint that we're looking at right now on Canvas. So let me pull it up and you tell me if you can see it. Do you see this? Somebody will have to speak because I can't see my screen. Can people see this PowerPoint? Yes, you can see it.
Just the 4 different screens for the 4 different
glaucomas?
Yeah.
No, it wasn't. It was something else. I'll show it to you afterwards. Please have somebody remind me to show you because I think it will help in the future. or when you're studying for the exam. Okay, so we're going to talk about glaucoma here. And glaucoma is usually a group of eye diseases, and they're characterized by the obstruction of the outflow of aqueous humor. And what happens there is that you have an increase of intraocular pressure. So the aqueous humor, if we went back, is in front of the lens, not the cornea. Well, sometimes it's in front of the cornea as well. But it's a liquid that is circulating around and gets reabsorbed into the mainstream and is produced and then reabsorbed again and then produced again. And so it keeps the eye lubricated. So what happens, and I think I've caused some confusion, and that happens frequently. So I'm sure I'm going to try and beat you to the text after the lecture because there'll be questions. When we went back at the very, very, very start of the lecture, and there was the picture of the eyeball, I said the aqueous humor was on the inside of the eyeball, and it helps. That's the vitreous. Okay, the jelly-like substance is the vitreous humor, and the liquid that is also inside is the aqueous humor, but the aqueous humor is fluid, not a jelly-like substance. And the fluid is on the outside as well, and it just keeps rotating by getting reabsorbed, draining and getting reabsorbed and reproduced, and that type of thing. So when there is an obstruction of flow of that fluid out and around the eyeball, then there is this intraocular pressure that develops. So what does that do to the pressure in the middle of the eye? It increases, and since you have a jelly-like substance, the vitreous humor in the back of the eye, in the eyeball itself, then you start getting all this extra volume of fluid, and then the fluid will compress the retina, which can lead to changes in the optic nerve and ultimate blindness. So what you have with glaucoma is this obstruction of outflow of the aqueous humor. And so it's starting to build up within the eyeball itself, and then that is going to compress the retina and then ultimately destroy the retina and cause blindness. So this is what a person looks like that has 20/20 vision, but then we're starting to get glaucoma. And when you are starting to compress the retina here, then you start losing your sight. And remember, we talked about macular degeneration earlier. This is actually just the opposite of macular degeneration. So macular degeneration, let me see if I have a side of it page. No, I don't. So macular degeneration begins with degeneration of the macula at the back of the eye. And so you begin not having vision here, but you only have peripheral vision. Glaucoma is is the opposite. So you have your regular vision, but then your periphery starts to be lost. And then as it gets worse and worse, you get down to all you can see is this little hole of sight in middle of your vision. So next to cataracts, glaucoma is the second leading cause of blindness in the world, and it causes irreversible blindness. And it is definitely the leading cause of blindness among African Americans. Now, there is primary glaucoma and there's secondary glaucoma. So let's talk about that for just a minute. First of all, there is primary glaucoma, and primary open angle glaucoma usually occurs when the drainage system of the eye degenerates and subsequently blocks the flow of aqueous humor, and that elevates the intraocular pressure, just like we talked about. But acute angle closure glaucoma is when there's a narrowing or closure of the anterior chamber angle, which also provides drainage for the aqueous humor. The thing about this acute, and this should give you, and this should give you a hint to which is which here, because you're going to need to know which is which. Acute means that it is quick onset. This is a gradual. Primary open angle glaucoma is a gradual onset. It worsens with time. Acute angle closure glaucoma is a sudden onset. It will do the same thing as this, put pressure on the retina, and then can damage the optic nerve because it will put pressure eventually on the optic nerve. But it has to be treated within 24 hours to prevent permanent blindness. So you're going to have this person have extreme pain, and it will be a red eye. The person will have a red eye, but it has to be treated. It's considered an emergent situation. Secondary glaucoma is when a person has developed glaucoma, there's intraocular pressure that is causing pressure compression on the retina, but it's because the person has had some kind of eye surgery. So it is not, it would not normally happen, but because the person has had some kind of eye surgery, then it's called secondary glaucoma. Developmental glaucoma occurs in infants and children and is pretty rare. So what are the signs and symptoms of glaucoma? Let's see if we have it. So let's go back over this just a minute. With open angle glaucoma, it develops bilaterally, and usually there is a gradual onset, as we talked about earlier. It's painless, but if the person doesn't get their eye drops every day, that pressure will continue to grow and they will eventually get blind. There is no cure for glaucoma, but you can retard or slow its progression. With acute angle closure glaucoma, it can develop in just one eye, and it's an acute onset, as we said before. It's severe pain, blurred vision, rainbows around lights, photophobia. So the increased ocular pressure can be so great that it can cause a person to have nausea and vomiting. And like I said, it has to be treated within 24 hours or the person will permanently lose their sight. Okay, so let's describe the medical management of patients experiencing glaucoma. So let me make sure I got my notes here. Okay, so there are things about it is, and I have to tell you people, this is kind of one of those that looks like a select all that apply type questions to me. And this is actually found in two different sections of the test that we're going to be talking about. So I would definitely mark this as the slide that you want to memorize. And so if a person is developing glaucoma, there are certain things that we want to do to help prevent an increase in intraocular pressure. So anytime you bend at the waist, it's going to increase intraocular pressure. If you lift objects more than 10 pounds, it's going to cause kind of a strain, which will increase intraocular pressure. anytime you sneeze or cough or blow your nose, it's going to increase intraocular pressure. If you're straining to have a bowel movement, then there's going to be intraocular pressure. You would definitely want to make sure that the patient's on a over-the-counter stool softener. If they're vomiting, that's going to increase their intraocular pressure. If having sexual intercourse is going to increase intraocular pressure. I won't describe that for you. Keeping the head in a dependent position. What does that mean? What the hell does that mean? I'm just reading Mark's question here. Will it look black around the peripherals as well? Are we talking about glaucoma? Yes, definitely. It's a tunnel vision. It's a type of tunnel vision that you have with glaucoma. Let's go back to my question. What does keeping the head in a dependent position mean? Nope. Remember, dependent is gravity. So what we're talking about here is that when people have a lot of eye surgeries, sometimes there'll be a little tiny gas bubble that is inserted into the vitreous humor. And when a person is in the prone position with their face down, then there is, or if they've been way down to touch their toes or that type of thing, then what is happening is that gas bubble will float up against the retina and compress the retina. So again, it's going to, gas bubbles are going to float to the top. And if the top of your position is putting pressure on the retina, then it's going to cause damage as if it were intraocular pressure. Okay, and wearing tight shirt collars, you really, to me, I have not really understood this much, because it's like you really have to have tight shirt collars to increase the pressure within your eyeball. I'm just saying. All right, so the thing about people, before we go into cataracts, the thing about people that have glaucoma is that they're going to need lifelong use of eye drop medications twice or more daily. And the prescription is going to be written by the physician that says that how many drops that they get each time that you administer the medication. And they will tell you that the patients do not want to lose their eyesight any further than it is. So the patients will be very vocal about making sure that they get their eye drops, and usually it's early in the morning and then before they go to bed at night. So there are certain medications, though, regardless of how they're taken or given, are contraindicated and can result in blindness if you give it to a patient with glaucoma. So mydriatic medications are contraindicated in acute angle closure glaucoma because they can cause an acute episode of an increased intraocular pressure by dilating the pupil and pushing the iris back, which blocks the outflow of aqueous humor even more. Miotic medications constrict the pupil and so may be given to patients with acute angle closure glaucoma. So you again have to be very, very careful and know what you're giving and when it's contraindicated and the adverse effects that they have before you give any medication at all. Okay, any questions about glaucoma? fine. Moving forward, we're talking about cataracts. Now, cataracts, we'll talk about them a little bit, and surgical intervention that can remove the cataract. But as I said at the beginning of the lecture, but I don't know if it was recorded or not because it took 3 or 4 minutes to have somebody remind me to record. But we're using cataracts as an example of eye surgery, but the guidelines for interventions are going, and the nursing care given to somebody for cataract surgery are going to be the same for any type of eye surgery. So you need to remember this. And basically the thing is that with any type of eye surgery, you are going to have be at great risk for infection and great risk for intraocular pressure. So that's kind of what we're building around today when we talk about cataracts. So cataracts is an opacity of the lens, and it can cause very blurred vision or distorted vision. It can cause glare problems. So a lot of times people have problems driving at night because of the glare of headlights. In very advanced cases, cataracts can cause blindness. And cataracts really are a significant cause for blindness all around the world. So it's very, very common as a person ages to develop cataracts, and they develop slowly over time. And I remember back in Oklahoma that our little technical college there had a vision program, and you could go down and get free eye exams. And I went down there and the doctor told me, and this was probably 12 years ago, he says, well, you got cataracts developing. I give you 10 years before you're going to have them removed. Well, it's been 12 years, and I do have pretty blurry vision. And I did, in fact, go and schedule a cataract surgery. But I have to tell you, people, it's the most damn expensive surgery I've ever seen, because Medicare will pay for basic cataract surgery removal or cataract removal, but it doesn't pay for a lens. And if you want it done by laser instead of a surgeon holding the scalpel by hand, then it's an extra $2,000. And then if you want the lens to be a corrective lens that they put in, that's another $6,000. And then they don't do 2 eyes at once. They only do it 1 at a time. And so that's extra operating room expenses. It basically, after insurance, my cost was going to be $9,000. So I thought, well, I'm just going to stay blind a little bit longer. But older age accounts for the vast majority of cataracts related to degenerative effects of the eye. But there's other things that can cause cataracts. Poor nutrition can, metabolic insults, excessive exposure to sunlight, trauma, certain medications such as cortisone can speed the development of cataracts. So just recognize that the most common cause is age or aging, but there are other contributing factors that will cause a person to develop cataracts. As I talked about, there's microsurgical techniques that are combined with intraocular lens implantation that will restore normal vision to a person. So it's readily treatable. This is kind of what you're looking at for a person that has cataract. This is normal vision, of course, and this is where you're at, and this is my world right here without my glasses. Yeah, it's pretty bad. And even with my glasses, it's kind of bad. Okay, so here, another misplacement of the slide writing. Anyway, risk factors: age, smoking, alcohol, sunlight exposure, low education, poor lifestyles, metabolic syndrome, HIV/AIDS systemic corticosteroid use. All right, so let's talk about education. We have, with any kind of surgery, you're going to have preoperative education, and then you're going to have postoperative education. So with preoperative care, the depth perception, the patient needs to be told that depth perception may be affected by the eye surgery. So they'll have a potential for falls because they can't determine where the stair is. And trust me, oh my gosh, even without my glasses, I sit there and I look at a stairs for a long period of time because it's like, how deep is it? How deep do I have to go? Or if I'm coming upstairs, how high is it? How high do I have to lift my leg? It's the saddest thing. It really is the saddest thing in the world to get old. I hate it. So, you know, there are times when cataracts get so bad that you have to ambulate with assistance. I never go upstairs. I never go downstairs unless I have a handrail, because I have this huge fear of falling and broke my ankle when I was in my 40s. Don't want that to happen again. It is the patient, you need to tell the patient that they will experience some mild itching. It's not horrible. We need to teach them how to correctly administer their eye drops or any other medication. We need to teach them to wear dark glasses outdoors to prevent ultraviolet rays coming in and doing some more damage. And if they have pain, worsening pain after the surgery, they need to notify the physician immediately. If they have any increase in bloody discharge, or if they have any kind of sudden loss of vision, they need to notify the physician immediately. And make sure that you talk to the patients about any questions that they have, any fears that they have about the upcoming surgery. So immediately after postoperative care, after a person has had cataract removal, it's amazing. I have had so many people that have told me after their cataract surgery, they sit the patient up and they look up at the clock on the wall and they can read the clock for the first time. So the results of the surgery are immediate, but you need to make sure that, again, you administer your eye drops accordingly, antibiotics. You will administer a steroid ointment to reduce inflammation and thus intraocular pressure. And typically you don't put an eye patch over the eyes that has had the surgery. You want to teach them to wear dark glasses. I think we already talked about this. Mild itching and a bloodshot appearance is going to happen. Also, after these surgeries, there's a creamy white, dry, crusty drainage on the eyelids or lashes, and that's normal. They just need to clean them off and teach them how to clean it off appropriately, like you did when you were bathing in giving a bed bath to somebody, from a cool washcloth from in to the outer aspects of the eye. You do want to control any pain with Tylenol. It may be Percocet if the pain is really quite strong. You want to have the patient avoid taking any aspirin because it may increase the risk of bleeding, and avoid those activities that increase intraocular pressure. Who did we have that intervention with? What kind of disease process were we talking about? You're sleeping. Wake up! I know you're sleeping in there. I can tell. Thank you, McKenna. Glaucoma. She was listening to her sleep. Oh, and Amy did too. All right. So again, same slide as there was before with glaucoma. So again, make sure you know those different interventions. You need to contact the ophthalmologist or surgeon if the pain is so great that there's nausea and vomiting, because that will increase the IOP. Also, if there's any signs and symptoms of infection, which is increasing the redness of the eye, if there's pain, if there's a change in vision, if there's tears, if there's photophobia, if there's yellow or green drainage, which is different than creamy white, if there's any unusual swelling or bruising that may be indicative of bleeding, reduced vision, and flashes of light or floating sheeps that not floating sheep, but floating shape with possible retina detachment. Okay, so home care. Look at this first sentence again. Avoid activities with IOP. So administer eye drops several times a day for 2 to 4 weeks per the doctor's order. And then you can wash your hair after a day or two by tipping your hair backwards. You don't want the shower head or the shower water to be going over the eyes. Avoid cooking and doing light housework. Avoid vacuuming because that can cause increased ocular pressure, and do not drive or participate in sports. So I have just put this on here from your fundamentals workbook volume 2 so that you know how to administer an eye patch again. I have included this on here, what you need to do, how to administer eye drops. This is for patients with reduced vision, but it's also for people that glaucoma, or for somebody that has cataract surgery and needs eye drops. Then you have your gel that you can antibiotic ointment that you put in, review how to administer that. And then identify nursing interventions that assist patients with partial or total hearing loss. So we're going to go into that in just a minute, but before we do, let's take a little break. So it's 9:45. Let's go until 9:50, and we'll come back. Okay, we're back. So there's just a couple of things that I wanted to reiterate. Let me go back just to here. Okay, so one thing I wanted to mention, yes, you can go back to your fundamentals book, volume 2, to look at how to insert optic eye drops correctly. But I just wanted to mention, if the person is wearing contact lenses, then have them wait about 15 minutes after they have inserted the eye drop or the medication into the eye before they put their contact lenses back on. And then also, it doesn't really matter so much with ointment when you're putting in eye ointment, but when you're putting in eye drops, the person really should be in a high Fowler's position with the head tilted slightly backward. And we do this unless it's contraindicated, of course, but an upright position keeps the eye drops in the eye and prevents the medication from draining into the lacrimal duct. And so it helps to keep the medication there as much as possible. All right, I thought this would probably be a good time to Ashley. Are you there, Ashley? Say yes, Ashley. Ashley Hyde is going to give us a presentation on nursing care that you give patients that are visually impaired, since we've talked about patients that have glaucoma or if they have cataracts before surgery. There's Ashley. Okay, this is how I found it to work. Of course, that doesn't mean anything, but in the past, what I've done is pull up your PowerPoint, and then as you narrate through, I will just click on the slide. So let me get this shared screen up and going. And then let me get your slideshow going. And then let me hit slideshow from beginning. Okay, now the problem with this method that I have, I can see no comments. I can only hear. So does everybody see the PowerPoint?
Yes, we see it.
Okay, and so Ashley, are you good to go?
Yep.
All right, it's all yours.
Okay, so my presentation is on reduced vision or blindness. So blindness is the complete or almost complete absence of the sense of sight. Some people do consider the term blindness to be negative, and they might prefer the term visually impaired. Blindness can be caused by a number of different things like cancer, diabetes, hypertension, cataracts, glaucoma, and others. It can be permanent or transient, complete or partial, and sometimes only in the dark, which is referred to as night blindness. So nursing care starts by just understanding how to interact with the patient. If they are newly diagnosed or newly developed, they're going to need a lot of support during the grieving process. This is a huge thing to lose, and Vicki mentioned this at the beginning of the lecture, but like our senses are just something that we kind of take for granted and don't realize how lucky we are to have them. So losing this would just be so devastating. So you just want to provide information on agencies, services, or devices that will be helpful, and definitely include the family in planning, because they're going to be quite involved with care and just helping that person out, especially if they're newly diagnosed. So I don't know why this is such a common thing, but they're not deaf, so you don't need to shout. It happens all the time, and I've even done it myself, and I don't know why it's a thing, but people really do shout when someone has a hearing or a visual impairment. Speak directly to the patient and not to others like family or friends that are in the room, and announce your arrival into the room. That's going to be super helpful because obviously they are not able to see who is coming in or out. So you need to let them know who you are. And I don't think I listed this, but also let them know when you leave as well so that they're not continuing on a conversation by themselves. So just explain everything you're doing to them. They aren't able to see like what you're going to do next, and that can be frightening to just continue on with the procedure and them not knowing what the heck is going on. So then ask them what you can assist them with. Don't assume that they do or don't need help with certain tasks. Let them be independent with what they're able to. This is huge. You really want to promote independent activities because they need to be able to get practice and get better so that when they go home, they can do some tasks on their own. And then provide reading material in extra large print. At my job, I know we offer menus that are like triple the size of a normal one, and the print is a lot larger so that if they do have some visual restrictions, it's a little bit easier for them to read the print. Post a sign on the door to identify the patient's vision status so that others are aware. There's a lot of times when you might be in another patient's room helping them, and one of your other patients calls and needs something, and someone else goes in that room to help you out and help the patient. And if they don't know that that patient is blind or visually impaired, that can be a big problem if they just let them get up and assist themselves to the bathroom. So just, it's a good idea to just let others know what's going on. Explain any activity going on that's within their earshot, just so that they're aware of what's going on. Tell the patient when you're going to touch them, just so that you don't startle them by placing your hands on them. Don't play with service animals if they have them. They're not there to be pet and play with, they're there to work. And then just explain the location of things in the room, like the call light, water, a urinal. We get a lot of cosmetic surgeries on my floor. So we get facelifts that get surgery on their eyelids often. And so they come up and they're so swollen and just not able to see. So what we'll do is we'll tape like either a rolled up piece of Coban or like a blue cap for an IV, just directly onto the call light, and then have them feel it, and it will just be a little raised bump. And that way it's easier for them to just grab the call light and feel where the nurse button is rather than just guessing and hoping you get the right button.
Okay, I've lost my cursor. Here's, oh, there it is. Okay.
So with eating, oftentimes they're going to be independent, but the easiest thing to do is just explain the location of the food in terms of a clock. So saying your pudding is at 3 o'clock, your mashed potatoes is at 12 o'clock, your chicken is at 9 o'clock. Just makes it a little bit easier for them to know where things are so that they can choose what they want to have a bite of. Ambulating, keep the area free from any clutter or objects that can be a hazard for them to trip or fall. Oftentimes they'll have a stick or a cane to help them avoid objects and know if there's something in the way. Let them grasp onto your arm or hand for assistance, and so you're kind of their guide. And just let them know if there's any steps or inclines or declines that are coming up and when to step up. And if you're transferring them to a chair, just place their hands on the armrest so that they know where their bottom is going, and you can kind of help guide their hips down. And then just be extra careful. It's easy to run into objects. So my cousin is, I actually have a slide about him in just a couple coming up, but he is legally blind. And just a quick story, we were in Germany and his family member, his sister, was guiding him on the streets and got distracted talking and wasn't paying attention and walked him like smack into a street pole. And so he had this huge goose egg on his forehead, and then he also, like, someone led him right into a car and he cut open his knee. So it's just really easy to forget that they're not able to see those things coming up. So just being extra cautious with objects as you're guiding them. Senses, oftentimes, if someone has an impairment with one of their senses, their other senses are going to be heightened. So with visually impaired, oftentimes it's their hearing or their touch that's kind of heightened and more awake than others, I guess. So this is my cousin, Jacob. He has, I hope I'm saying this right, uveitis, which is inflammation of the uvea. And so I asked him what some things that are helpful when he has had to go into either doctor's appointments or the hospital. And he said just having the nurse explain small things like where to sit or place his head by tapping on the bed so that he can hear the sound of where it's coming from and feel the vibration on the bed. And then giving a point of reference to focus on if they're checking out his eyes, which when we check for Perla, we say, look at the bridge of my nose, or just giving them kind of a point to focus on. And then just explaining where things are, or if they're handing an object to him, having them grasp his hand before placing the object into his palm, just so he kind of has some stability when he's grabbing something. Some things that are not so helpful, he has asked where, this is in a hospital too. He's asked where something is and someone will say, oh, it's right there. And he's like, well, I'm blind, I can't see that. And then he was looking for something and the nurse couldn't find it. And she said, oh, sorry, I just must be blind. And he was like, well, me too, join the club. So just kind of being mindful of what you're saying. And then this is just a little video, kind of just similar to like having other senses heightened. So he's like legally blind, he can't see anything, but this is just a little clip of him. He's really good at musical instruments. I think it plays it twice.
Oh, there it goes. I couldn't make it go.
Yeah.
There you go.
So just in conclusion, don't treat them as if they're incompetent. They're still very independent and want to do things on their own. Put yourself in their shoes. Just imagine what it would be like if you suddenly lost your sight. It would be pretty devastating. Explain what you're doing, probably in further detail than you normally would for someone who can see everything, just to kind of give them a heads up and to put them at ease. Ask them what you can help them with. Don't just assume that they need help with everything, and then just help prevent any trips or falls. So for my learning activity, just put your answer in the chat. You get a new admit in room 302. The patient is a 55-year-old man with severely impaired vision. What are some things you will do while caring for this patient during his stay?
Perfect. I really loved this presentation just because of I was watching your cousin there, and it's so amazing to me that here they cannot see. He's blind, so how does he know exactly how much distance to move to hit the next tone? on his xylophone, and it's just amazing to me. It's just amazing to me. It's a miracle. Now, there's one thing too that I wanted to bring up about walking or assisting a blind person walking, and I used to do this as an activity when I was teaching CNA back in the day. But one thing that is very helpful, have you ever, you're playing a game or somebody and somebody puts a blindfold on you and then they lead you with the hand, and like Ashley was saying, you can run into things. The person that is blind can run into things. So what we had them do is walk slightly, have their right hand or their left hand on the person, the leader's shoulder, and they walk slightly behind the leader. And then they have, first of all, a sense of protection or safety, because if the leader is going to run into something, they're going to protect the blind person, but also they can sense the movement of the leader. If the person is going up a stair or going off the curb, they sense the movement of the leader's body, and the patient can follow, has that split second to determine where they should go or how they should go. And it keeps them at a pretty a pace that is not extremely slow or hesitant. So there are little things that you learn to do with caring for someone that's blind or assisting someone that's blind. One thing that Ashley noted that is very important to remember, and this was kind of stressed in the last lectures as well, is keeping the person as independent as possible. You want them to maintain their highest level of functioning. It doesn't mean that they're going to be like they were before they lost their sight, but it does mean that they will be as independent as they possibly can, which affects their self-esteem and the way they look at themselves. So excellent job. Now let me see if I can get back out of this again, and then we go back to taking that off. Boom! Did you hear it? Amazing. All right, let's move on. Oh, let's go back for a minute. Okay, so we are going to identify the person that has, or at least talk about nursing cares for somebody that has a partial or total hearing loss. So sometimes, and this is, I couldn't believe this lady got up in church and said this. So she's up in church and she's talking about how her husband had a terrible scare that day because he couldn't hear anything that she was saying, which I'm sure was very disappointing to her. But upon examination, she found that her husband had kind of impacted his ears with cotton. By cleaning his ears all the time. Apparently, when he cleans his ears, he loses a little bit of cotton from the cotton swab every time, or from the Q-tip every time. And so why would she get up and talk about that in church? I don't know. I was not too spiritually moved by that at all. Anyway, so impacted cerumen can be a buildup of earwax, and there's nothing really wrong with the patient's hearing. It's just that they have an occlusion of their external auditory canal, and so thus no sound vibrations can travel to the tympanic membrane. So this can cause a partial or total hearing loss. Presbycusis is a degeneration of the organ of Corti, which is a result of aging. So it's more of a sensory hearing loss. And then tinnitus is the ringing in the ears that is a result of infection in the cochlea or from trauma. I know that a friend of mine was dating a man whose young daughter, I guess, he was in his 60s, and I guess way back when his daughter was 3 or 4, he was bending down to do something, and she came running up and popped him in the ears. And for all those years, you're talking 50, 30 years, whatever, he had this ringing in his ears. And he talked about how that just absolutely drove him crazy for years before he learned to disassociate with that. So just beware of that. Again, the impacted cerumen can come from just the accumulation of dirt or foreign objects in there, or if people are wearing hearing aids all the time, then the hearing or the cerumen can get packed into those external auditory canals. So again, you want to go to your volume 2 of your fundamentals book to review how you insert medication into the ear. This was also done in your baseline simulation when you were administering medications. So review that. And then I'm going to leave this. This was just part of my lecture because the person in the last time did not participate in this. So let me pull up. I can't remember who's doing it. Nope. Alina? Did we do Alina already? No, we didn't. Okay, Alina. We're going to pull up Alina's PowerPoint. Alina, are you there?
Yes. Can you guys hear me?
Yes, you're fabulous, but let me pull this up and see how I need to do this. Just a minute. I got to go through my steps in order. If we don't go in order, it doesn't work. Okay, are we good to go?
Yeah, Vicky, can you see me? I don't think my webcam's working. I'm not sure though.
Okay, I can't see you because all I have is your PowerPoint on my full screen so that you guys have a full PowerPoint. So that's why you have to just kind of talk me through this because I don't see any comments. I can't see your faces. You can all be flipping me off, there's no judgment here. Go ahead and do it. But let's give Alina our attention now. Hello.
Oh, the PowerPoint, I only see the one that you just had on the from
Oh, you do? Okay, let me pull this back off for just a minute. Like I said, if I don't go in the exact correct order of this. This happened the other day, remember?
Yeah.
Oh, do we love the software? We do. We do. Give me a couple more tries.
It's okay. I'm still trying with my webcam, but I don't think it's
okay. Well, see, you didn't put my webcam either today, so.
Yeah, I'm not sure. It just keeps saying it's locked, but I keep giving like big blue button permission, so I'm really not sure what's happening.
All right, let's just hold on for one more minute. I hope you guys have got a drink or some treats that you're working on right now. Oh, it's coming. All right, just a minute. Now, here's this, and here's Okay, does it take full screen now?
Yeah, it is.
Okay, perfect.
Okay, so for my presentation, we're going to be doing care of patients with reduced hearing and or deafness. So patients with reduced hearing, hearing loss can be due to a couple of things. It can be due to old age, genetics, or infection. People can be either deaf, where they have complete hearing loss, or they can only have partial hearing loss, which to my experience, they like to be called hard of hearing, or they call themselves hard of hearing. It also depends on the type of damage that's within the ear. So there's conductive hearing loss, sensory neural hearing loss, or mixed hearing loss, which is kind of between the both of them. And then when you do get a patient with reduced hearing, audiologists can help with their treating because usually as nurses, we can't really, we all know we can't diagnose, but it can also just be hard to pinpoint what kind of hearing loss they're suffering from. So audiologists can kind of pinpoint the exact hearing loss they're suffering from, and it can be beneficial to their care because they can provide us with a little bit more specific interventions. So my PowerPoint is on the nursing care, but to be able to have the nursing care that's beneficial to each patient, you kind of have to assess the patient really, really well. So there's a variety of tests. So there's the test that we've all done, which is the Whisper test and Romberg's test, which, as mentioned previously, Romberg's test does test for balance, but it's kind of very dependent on the ears almost, because the ears and their like fluid in them is kind of what creates your balance a little bit or supports it the most. So if someone doesn't really do good on the Whisper test or Romberg's test, then you would go into more specialized hearing tests to kind of pinpoint what part of their hearing is suffering. So then there's also the Rhine test and the Weber test. They are both more specialized tests using the tuning fork, which we've all kind of used when you did the vibration like the vibration test during our comprehensive health assessment. It's the one where you would like hit it against your hand and it would vibrate. So for Rhine test and Weber test, they both only differentiate by where you place the tuning fork. And then if hearing loss is detected, both using the Rhine test or the Weber test, then that's when you would do an audiometric test. And that is to determine the type and degree of hearing loss. Once again, to kind of pinpoint where their hearing is suffering in or what part of their ears aren't really working as well. And then in very, very young patients, if they have hearing loss, if they're deaf, if they're just hard of hearing, I feel like, again, because like Vicky said, we all have these senses, so we don't really realize, but if you didn't hear what words sounded like, it would be very hard to kind of learn reading and writing and be able to speak properly because you wouldn't be able to hear what the words are supposed to sound like. So in younger patients or patients who have been hard of hearing for a majority of their life, their speech can often be different. So if you have a younger patient, often speech pathologists would be recommended to include on your healthcare team to kind of communicate with them and help them a little bit with that. And so patients with reduced hearing, it is very important for the nurse to know the type of hearing loss, like I've said, just because it kind of helps on where you need to do your interventions. If the patient is on any medications, this is kind of specific to one, eardrops, and two, if any of your medications are ototoxic, which I'll talk a little bit about later. And then if they use any hearing devices, hearing assistive devices, this can be in either older or younger patients. It kind of really is just about hearing aids. The type of hearing aids and everything, I don't really go in depth with that, but it's just knowing if they use them, so you know if they need to have them in, if there's any specific like charging. I know where I work, we have to take their hearing aids at night so that they don't lose them, and then we give them back to them in the morning when we get them up and get them ready. And then presbycusis, I'm not sure if I said that right, but that's the loss of hearing high-pitched sounds. So a lot of older people can kind of suffer from this. And I feel like when people are hard of hearing, you kind of think to speak to them loudly and like not scream at them, but just speak at them a little bit louder. But for presbycusis, it's not really the loudness that they're losing, it's the pitch. So when you're speaking really loud, sometimes all your words sound the same pitch because you're speaking so loud. And this actually makes it harder for them to hear because they can't really pronounce or differentiate the sounds that you're making. So when you're talking to hard of hearing patients, it's a little bit better just to speak kind of slow, not really too slow where like you're treating them like they're dumb, like they're still mostly independent and everything, but just so that you're pronouncing every word and every letter and everything so that it's easier for them to understand. And then be aware that inner hearing loss and damage can also affect the patient's sense of balance. This once again goes back to the Romberg's test, because if someone has inner hearing loss, they can kind of be very off balance. They might have an unsteady gait. And this is important because when you're conducting the Romberg's test, you kind of want to stand a little bit closer so that they don't fall, or when you're assisting them with walking and everything, you just kind of want to ensure that you're doing that because they do have that lost sense of balance. And so it's a little bit easier for them to be a fall. So for nursing care, it is extremely helpful to actually kind of demonstrate and show the patient what procedures or cares you're about to do. Still try your best to communicate verbally, but especially if they're completely deaf and you don't know ASL. I mean, I know most hospital policy, you would have to get an actual certified ASL translator in there. But if they're just hard of hearing and everything, it'll be probably really helpful so that you demonstrate what you're going to do as you're talking about it so that they can see what you're about to do. And once again, just emphasizing that this isn't for treating an adult patient like a child, but more so that it's a little bit easier for them to understand what you're about to do. So let's say you're about to make their bed and you just want to transfer them to the chair. You can just show them, you could bring the chair and say, oh, I want you to sit in this chair while I make your bed or while I clean your room or anything, and just kind of show what you're going to do so that they understand a little bit better. If a younger patient is experiencing hearing loss, it is very important to include the family because they will be the ones caring for them, and offer them more information on different services. These can include, like I said, speech pathologists, so that their child can kind of have the most effective learning of their speech and of their disorder really shouldn't hold them back from doing anything. I know at my high school I had plenty of people who were hard of hearing and spoke relatively fine. There was a couple words that you could tell that it was a little bit different, but it wasn't anything major. And I think that's definitely because they kind of caught it young and treated them normal, but also kind of adhering to that difference. And then also in younger patients, many therapeutic services, any counseling, maybe showing them different groups where there are other kids that are hard of hearing, because I know that having a hearing aid at a young age, it can definitely affect you knowing that no one else has that but you. So being introduced to children that are also experiencing what you're experiencing, it can help you be a little bit more positive to everything going on. And then this is what I was talking about, autotoxic medications. So this includes certain antibiotics or diuretics. Autotoxic, I mean, we probably you probably know what that is just by the words, but it's just any medications that are harmful to the ears. And this is because some medications can kind of harm the ears more. So if you do see these medications in certain antibiotics or diuretics, then it's kind of important just to double check with your physician or your doctor or whoever prescribed them to be sure that it's okay that that patient has them. And then children that are hearing impaired, they may have signals that they use at home and they use with their parents. Maybe they have different signals to eat or different signals to say they need to use the restroom or anything. And these can be ASL, or they can just be signals that they've kind of learned while talking with their parents and their siblings or anyone else at home that helps them. So I would be sure to ask about this just so that so that when the child is doing those signals, you're not kind of just oh my gosh, what is this child doing? But you can actually help them and adjust to that. And then adults that are hearing impaired, like I said, they can have developed speech difficulties. So it's important to be patient with them and do your best to understand. This kind of goes back in not trying to finish their sentences or not trying to come to a conclusion for them, but just letting them talk. And then maybe if you need any clarification, asking any questions about that. And then provide diagrams and written instructions when possible. They can still read, they can still see everything. So if you trying to demonstrate isn't really working, then diagrams will probably be very helpful for different procedures or different cares so that they can actually see what you're about to do and you can just point to it. And then written instructions because they can still read and everything. So if they're going to go into a very intensive procedure and you want them to know everything about it, written instructions would probably be the best because it would be a lot to explain and they can easily kind of get thrown off if they don't hear one word and then they're trying to rethink of what they're trying to hear and everything. But if they have written instructions, then it's very easy for them to point to what they don't understand, and then you could possibly explain those in depth. But the written instructions just kind of give them the overview of what's about to happen. And then similar to what Vicky was just teaching about, it is very important to instruct the patient on proper ear cleaning techniques. buildup of earwax can exacerbate hearing problems, or as she said, like cotton getting stuck in the ears. So I know it's like the most common thing to clean your ears with cotton swabs and stuff, but it's been a lot of recent studies saying that that's actually really not good because you can kind of damage your tympanic membrane, or you can just, like you said, leave cotton in it, spread the earwax around, or kind of like push it back, so it's just kind of building up. So it's important for them to know like the proper ways to do it. I know there's also a lot of new at-home ways to clean your ears, like those like suction things or anything. You definitely want to have conversations in places without excess noise. This is kind of a given, but it's just something to really be aware of if you're trying to tell them something while they're in the hallway and there's a lot of noise, or if they're in there and all their family is talking at the same time that you're trying to talk to them. This is just going to make it harder for them to hear you. So you want to be sure to have one-on-one conversations, or have the family understand that like when you're talking to them and explaining important things, that the noise level needs to be down so that they're able just to focus on your voice. You also want to educate the patient on staying away from loud noises. This can be in either recreational environments like concerts and air shows, stuff like that, or in work environments. There's plenty of people who like work in high noise areas like construction or anything like that. This can just damage their ears more. And exposure to loud noises in recreational work environments can actually cause ear damage too. So you just want to be sure to educate patients. It's very preemptive teaching, but it's very helpful. You want to talk to the patient clearly, not too fast. I know I tend to talk fast, so I have a man who's actually hard of hearing that I work with, and so sometimes he has to tell me like I can't really understand what you're saying, because I'm like, okay, I talk too fast and I don't really realize. So it's just kind of good to be aware of that if you're talking way too fast, because your words can kind of blend together, and for people who are hard of hearing, this makes it even more hard for them to understand what you're saying. And then this is also really hard because of COVID, but if possible, don't block your lips and speak directly in front of them, as some patients prefer to lip read over ASL. This is also for some patients that have been hard of hearing for most of their life, because it just was easier for them to kind of adjust to lip reading on top of like hearing whatever words they can or hearing to the best of their ability. Again, I know because of COVID, it's a little bit harder, but if it's possible in any case, just don't block your lips, because it'll just kind of make it a little harder for them to understand. And speak like at eye level, or at least so that you're right in front of their face. Like don't speak with your head to the side or looking somewhere else, because then they probably won't get as much information as they would if you were speaking directly in front of them. And then it's really easy to forget that eardrops are still medication. That sounds kind of dumb, but like eardrops, they still have their own like storage. Like you have to store them at room temperature. You have to understand like their delivery. If you do 1 drop in each ear or 2 drops in one ear, if you do it in the morning or at night, you should still be aware of their side effects and contraindications, just to note those. And if there is any contraindications, to maybe ask the doctor about the prescription and just double check that they understand those as well. And then for side effects, just to know if it's going to make them tired, if it's going to make them, I don't know if they make them dizzy, but if it makes them anything other than what it's supposed to. And then you also want to note the expiration date, because again, they're medications, so they do still expire, and you never want to give expired medication to your patients. And then that's pretty much it. There's also, it's just kind of a lot to consider, but when someone's hard of hearing, you just want to make sure that you're accommodating them in every way possible. They still are independent. They're still able to do almost everything for themselves. It's really hard of hearing. It just kind of comes into play when you're talking with people or when you're trying to understand other things. But just offer them help when they need it, again, with that lost sense of balance and everything. But I think it's the best to promote independence and understand their disorder to the fullest, so that you're able to provide the best and most specialized care. And then I have like kind of a 2-part activity. So the first one, it's a YouTube link. I'm not sure if Vicky's able to do it. If not, maybe she can just like copy it. But it's similar to what we've done in class before, where it's one of those sounds like, oh, if you can hear it at this time, or when you can hear it. I know the one we did in class was based on age, but this one's kind of a funnier one, because the ranges all have like kind of funny names. So are you able to access that link? Vicky?
Let's see.
Okay, perfect. So just type in the chat when you're able to hear the sound. Again, they're pretty funny. So if you can, like, once you hear it, just like type in the chat really fast when you can do it.
Hello, would you like to try a hearing test for high-pitched sounds? Please make sure that you carry out the test under quiet conditions, without any background noise, and of course, don't forget to use enclosed headphones. Pause the video as soon as you start hearing a high-pitched sound in order to see your results. Starting in 5, 4, 3, 2, 1.
Oh, I'm not sure if it works. I can't hear the noise.
I can't either. I didn't know if it was iPhone. It was just
No,
me.
like I was able to hear it at Unbelievable. That's why I wasn't sure.
Let me just finish it. It's going through several relay
I was
stations.
just able to hear it.
It doesn't surprise me. But if they did it individually, oh, I am totally deaf.
So I think mirroring it kind of messed it up because like before I was able to hear it at Unbelievable, but I didn't hear it right now till like grandma's. So
Look at me, 90-year-old World War II artillery veteran. Yeah, that's me.
so it was a little bit messed up because we're mirroring it because again I had done it like a couple times before to see where I had it to make sure it would be able to work, but if you just want to look it up and do it on your own, that's oh, Sydney, your dog freaked out. I was wondering that too, if like dogs would be able to hear it.
You're good. Should we do it again? Since it just takes a few seconds. And we know what we're looking for.
Yeah, mine was Unbelievable, but this time I couldn't hear it at all.
Hello, would you like to try a hearing test for high-pitched sounds? Or that you carry out the test under quiet conditions, without any background noise. Of course, don't forget to use enclosed headphones. Pause the video as soon as you start hearing a high-pitched sound in order to see your results. Starting in 5, 4, 3, 1.
Yeah, I can hear to the end.
Yeah, I still am a 90-year-old. I thought for sure I would improve on that, but I guess I didn't.
But okay, I wasn't sure if that would work, so I did have a part 2 of the activity, and that's more of my educational part.
Let me pull you up. Okay, let me scroll down here. There's that. Let's see. Current slide.
Okay, and then this is just a scenario. Just answer in the chat to one of the 2 questions. So Donovan is a 5-year-old boy who has just been diagnosed with hearing loss. What other members of the healthcare team might be involved in Donovan's care, and what teaching would be beneficial for Donovan's family to help adjust to the needs of Donovan due to his diagnosis?
Okay, so it would help if you guys would go and do that, chat, just so you get a little bit of review yourself from Lena's presentation. Excellent job. One thing I have to admit to you guys is that I personally, let's see, get this thing off. I personally am going through, I'm 67, okay? So, okay, just no judgment here, but I'm starting to lose my hearing. And it happens more so on cell phones than it does in person. Usually I'm pretty okay when I'm face to face with people or people are in a room or call after me. But on the cell phone, it's just absolutely terrible. And I got to tell you, my children are not the most patient children in the world. In fact, they're downright impatient. What can I say? And so, you know, they'll be talking to me on the phone. I try and talk with each of them once a week, and they'll be talking away and I can't hear. And I'll ask one time for them to repeat. And they will repeat usually okay without problems. But if I have to ask more than once, they get very annoyed that I'm consuming their time in their world. And so I have come to the point where when talking to my children, I don't ask more than once because it's embarrassing, okay? It's like they're so put out and so irritated. And most of us don't want to irritate people that we're communicating with. And so I miss half their conversations. It must be not be too horrible of a thing because they continue to talk and talk and talk and talk and talk and talk and are perfectly content that I don't ask questions about what they're talking about. So what I'm just trying to say to you, as you get older, it's not like I've been deaf my whole life. And so I've noticed that this is a loss and becoming a deficit to somebody that was perfectly capable of hearing everything and hearing a lot of things that probably I shouldn't have heard over the years. And I've noticed that this is a loss now. And so it's very embarrassing to me. And it's when I have to ask more than once and people get irritated with having to say things more than once. Or if they do repeat it, sometimes they will give you a shorter version of what they originally did. So just recognize that it has a huge impact on the patient or the person that has a hearing loss. I recognize that, yes, you want to go get an American Sign Language interpreter, but if hearing loss is due to the aging person, then I'm telling you, at 67, I don't want to learn ASL. And so most of us don't know ASL. And so we just haven't gotten accustomed to reading lips yet. Maybe we will get to a point where we get used to that. Usually people that have been deaf for long periods of time acclimate with that modification or that limitation of just reading lips. But for those of us that are older, we haven't quite learned that. Maybe we will, if we're face to face, we will learn to do that when our hearing gets really bad. But I just have to tell you from a personal point of view that it's an awareness of the person that they are getting older, that they are starting to get they're not what they used to be. And that is not a fun thing to recognize. Just got to say. All right. So let's look at disorders of the nose. We have rhinitis, which is inflammation of the nasal mucous membranes. And we have epistaxis. That's it, epistaxis, that is a nosebleed, and then sinusitis, sinusitis. Oh, dang it. This is what talking for 3 hours does to you. Sinusitis, which is, of course, inflammation of the sinuses. So the thing about rhinitis is that it may be complicated where a person will have sinusitis as well. But you're going to have nasal congestion, you'll have localized itching, sneezing, a sore throat. Oftentimes you're going to have drainage. Sometimes you'll have discharge. It can be viral. It can be from a bacterial cause. It may be accompanied by a fever. Sometimes it's difficult to differentiate the signs and symptoms from a cold with those of the flu. So basically, we treat viral rhinitis with symptoms or the symptoms of rhinitis. Because colds are caused by viruses, antibiotics are usually not effective, so we just have to treat the symptoms. It's acetaminophen can be used for generalized discomfort. Decongestions can be used for that can cause vasoconstriction, which will reduce the swelling. Cough syrups and cold medications should be used with caution because none of these things treat the underlying cause of the cold. And sometimes we're taking medication needlessly because they're not going to really help much. So rest and fluids are usually the most effective treatment for rhinitis. Epistasis is a nosebleed, as we talked about before. This is usually caused by a trauma, or if the mucous membranes get very dried out, you can blow your nose or wipe your nose, and it may cause some bleeding. The nose can either bleed from the anterior or the posterior regions. Anteriorly, nosebleeds are much more common, and they usually originate from a group of blood vessels that are close to the anterior portion of the nose. So it's pretty easy to fix an anterior nosebleed because you can stuff some cotton up there and put a little bit of compression on those vessels and control the bleeding. But the most common cause is dryness. And when you live in a really dry environment, then the membranes will become very dried out and crack. So any kind of trauma or forced nose blowing or nose picking can cause the mucous membrane to bleed. Anything that reduces the blood's ability to clot, such as hemophilia or leukemia, or the regular use of aspirin, or if a person's on an anticoagulant, or if the person's on chemotherapy, all of this can predispose a person to nosebleeds. Also, we still use cocaine when we're working on the nose. If you're going to have any kind of neurosurgery, trust me, there will be cocaine in the OR room with you because of its vasoconstriction properties. I have to tell you, I was doing an externship on an operating room when I was an undergrad, and I got my butt chewed. Oh, it got chewed up and spit out because after a nasal surgery, they were looking for the cocaine because so much was administered. And then I just was cleaning up the OR afterwards, and I took that little cocaine and I threw it in the sharps container because I didn't want anybody to use that cocaine that shouldn't be using it. And it's a controlled drug. It needed to have a second nurse watch me waste it, and nobody saw me just throw it in the med or in the sharps container. So, oh my gosh, everybody was so mad at me. So I learned real fast that you just don't throw away cocaine in an OR. Wait and watch, have somebody watch you do it. So anyway, just know that cocaine can also cause nose bleeding because of the vasoconstriction, and oftentimes because of pressure in the nose, those blood vessels will break and bleed. So for therapeutic measures for somebody that has a nosebleed, you need to have them sit in the chair and lean slightly forward to avoid aspirating or swallowing blood. So if the patient swallows blood, it's going to make them sick. It's going to be very difficult to assess the extent of the bleeding because blood in the stomach, again, is going to make them sick. They're going to have nausea. They're going to vomit. And that is going to put increased pressure on the nerves. So really, to have a bad nosebleed, you need to compress those vessels for at least 5 to 10 minutes. So when a person is putting their head forward, and after 3 or 4 minutes, the bleeding seems to have stopped, and you think, okay, I'm good to go. Nope, you want to keep them down for that extra 5 to 10 minutes, because the slightest little thing like an etchu or cleaning the nose just a little bit after that nosebleed can cause the vessels to start bleeding again. So if first aid measures are ineffective in stopping the bleeding, then physicians may do a more invasive treatment. Sometimes I've seen Tampax stuck up there. Sometimes they will shoot this stuff up the nair, and it will kind of bubble up and absorb the blood. And again, it keeps it constricted for a longer period of time than it is comfortable to lean your head forward. So you always want to, if it's been a bad nosebleed with a lot of blood loss, you want to check the hemoglobin level for excessive blood loss. And if you can't get a nosebleed to stop in 10 to 15 minutes, you need to notify the physician. So the last thing we're talking about here is sinusitis, which is inflammation of the membranes of the sinuses that we talked about. It can be one or more. Oh, guess what? We're not recording, are we? Oh, yes, we are. Oh, good. I'm fine then. Were you guys needing something? I could hear talking back there. Oh, disappeared again. So if you need something, just shout out. Won't have my feelings hurt. I will be happy to stop. Okay, so where would we start up? Signs and symptoms? I don't know. Signs and symptoms of sinusitis. They'll have pain over the region of the affected sinuses, and they may have some purulent drainage or discharge. If the maxillary sinus is affected, the pain will be, I think I told you about this before, over the cheek and the upper teeth. If it's the ethmoid sinus, then the pain is going to occur behind and between the eyes. And if it's the forehead, then there's going to be a frontal sinusitis, which may be to a viral infection. And you may have a fever with that and general malaise. It all depends how bad it is. Okay, here we go. I am going to just briefly go over this, and then we're going to have our last student presentation. So first of all, the inability to smell affects the quality of life. Since such as the smell of a Christmas tree or flowers or coffee brewing may not be detectable anymore, and it diminishes their taste. There will usually be a nutritional decline because you can't smell food, and which again has reduced the taste. And then it can also be a safety hazard because you won't have the ability to smell smoke or a fire or a gas leak or spoiled food or that type of thing. And then a decreased sense of taste can result in the inability to taste spoiled or rotten food, which can happen, people. It can happen. All right, so let me. Okay, so okay, Mapiola. I don't think I've ever said your name before.
That's okay.
Did I just slaughter it?
A little bit, but that's okay, Vicki. I like
Oh,
it when you say
go
it.
ahead and tell me how you say your name.
You can just call me Mapu.
Mapu, I love that.
Yeah, just Mapu for short.
Oh, that's so cute. Okay,
Thank you.
let me start my never-ending attempt to make this work. Oh, it's gonna work. Okay, let me get you now up here, and let me get you show and from beginning. Okay, let's go for it.
Okay, so I'm doing nursing care of the elderly patient, so with decreased sense of taste and smell. And so basically, just like, is this normal with aging? So it's considered natural after the age of 60, and then other things can also contribute to the loss of taste and smell. So, like nasal and sinus problems, so like allergies, sinusitis, as Vicky said, and then nasal polyps. Also, some medications like beta blockers and ACE inhibitors. Some dental problems, so like if their dentures don't fit them correctly, then it makes it difficult for them to eat properly, which can also cause a decrease in how they are able to taste. Cigarette smoking, head or facial injury or mass, and then Alzheimer's disease and Parkinson's. So basically how aging affects the senses. So basically, you have taste bud cells and they regenerate every 2 weeks. And so you begin to lose that ability. They stop doing that at the age of 50. And then they also begin to lose their sensitivity as well during that time. And then also your sense of smell really plays a big role in what you're able to taste. And so the nerve endings, your olfactory nerve endings, and your mucus production also begins to decline, which also affects the way you taste and smell, basically. So why is this significant? So basically, if you're unable to taste your food, then you won't really want to eat it. And so a lot of old people just like will go without meals because it's not really enjoyable for them to eat anymore. Also, eating is a really big like social aspect of our lives. And so if you're not eating as much, then you're not able to, then you're not really having that opportunity of a mealtime to interact with other people, and your quality of life kind of declines since you're not really eating, not really socializing, and so it can lead to depression in old people. Also, since you're not able to taste anything, a lot of old people, they will like add like a ton of salt or a ton of sugar to their meals, and so that can kind of just increase your risk of having high blood pressure or diabetes. And then also, as Vicky said earlier, it's just like a safety hazard. If you're unable to smell, then you're unable to identify like leaking gas or smell smoke from a fire. And so, yeah. Okay, so some things that you can do for patients who have had the loss of taste. So just basically encouraging your patients to eat and like encourage them to eat nutritious meals as well, like things that they can that are healthy for them. And then also documenting the amount that they consume at each meal. I work with a lot of old people and a lot of old people that live at home. And so a lot of them they do Meals on Wheels, which is basically a program where they have meals brought to them. So like they'll have their lunch that's brought to them, and they're able to just have that one meal that they don't have to cook for themselves, and it's just kind of easy for them, and at least we know that they're getting something to eat. Because it also becomes difficult preparing your own food as well when you get older. And then also just educating patients on avoiding like the excess salt or sugar and trying to use other spices. The doctor that I work for tries to encourage our patients to use things like Mrs. Dash as a good alternative for them to use to eat. and they seem to like it a lot better. And then also just assessing for other underlying causes that you're able to treat, and like maybe like the dentures or something like that that could be contributing to that. And then also for nursing care for patients with the loss of smell. So just basically educating them on safety concerns. So with the gas, with spoiled foods, teaching them ways that they are able to detect those things without using their sense of smell. So like basically like looking at spoiled foods, making sure that they're looking at it and making sure that it looks good before they eat it, or having somebody else tell them if it smells bad. Also educating patients on being careful around chemical odors, such as like cleaning supplies, because if you're unable to smell it, then you won't really understand that, like how strong the cleaning supplies may be. And then also having carbon monoxide detectors in your home and how to manage it, making sure that they're changing like the batteries and stuff. And then again, treating for underlying causes. Okay, so I was hoping that there was going to be an announcement for my learning activity, but there was not. So I'll just basically explain it. So your ability to smell greatly affects what you're able to taste. So if you were to get like some Skittles, and if you were to plug your nose, if you put a Skittle in your mouth, you're not like, you wouldn't be able to distinguish the different flavors in it because it's the smell of each Skittle, which is basically what you're tasting, I guess, to say, if that makes sense. So basically my learning activity was just to have you guys like get some Skittles, or I was going to drop some off at school for you guys to pick up later. And so basically you just plug your nose and then see if you can try to distinguish each flavor, but really like without being able to smell, it's kind of hard to do that with each flavor. And since they're like the same consistency and like texture and stuff. So yeah. That's my learning activity.
Well, thank you, Mehu, and I apologize. I didn't see any instructions for that at all, so my bad for that. I was, and I will say that occasionally, every single time, I just find the PowerPoint, find the handout, upload.
No, that's okay. Thank you.
I do apologize for that, but bring the Skittles anytime. I promise I won't eat them. Well, maybe a bag or two, but hey, it's always good.
Okay, I'll bring them in. Thank you.
All right, so people, it's 11 o'clock. We have until 11:50. We're basically through everything that we have to get through. Chantel will not be teaching until 12:30. And so I am going to go ahead and let you guys go. I would at this time go ahead and do a review for the test, but I haven't prepared a review for the test. So I hate to give you a review just from my gut, but I will go ahead and record a review for the test and upload that in conferences so that you can review for the test for next Monday. So next Monday, exam number 3, the exam will cover skin, hair, and nails. It will cover the burn lecture, and it will cover sensory and any student presentation that was made during those lectures. I will not be including the burn lecture on my review because I think that the outline that I typed for that is sufficient. It covers everything that is going to be on the test. So just utilize that review. And did I open that by any chance? Does anybody know? Did I publish that? I was going to publish it after the lecture, after I made some corrections. Let's just see if I did that really quick. I'm pulling that up to see if that's published, just to make sure that I remember to do it. Hold on. A burn lecture outline is done. It's called the burn lecture outline. It's right under the burn guest speaker, Brad Wiggins, Zoom link in the module for skin, hair, and nails. So again, I won't be covering that in the review. It'll just be skin, hair, and nails and the sensory. All right, any questions at all? Let me get back to where I'm supposed to be. Is that really any place? Really, no. Okay, any questions at all? Let me scroll down, make sure I don't have any questions that I haven't missed. Yes, that would be helpful if you could do that, Vicki. Could you open the quiz up earlier than 2 p.m. today? Yes, I will make that happen, Amy. Is there pediatric and adult? Yes, there will be pediatric and adult, both sensory on the exam, but you haven't, we won't post the blueprint until after. I think Chantel says it's always going to be posted on a Wednesday because that'll give her time to give her lecture, and then usually 9 times out of 10 we always have some pass-offs that we have to do in the afternoon. So she doesn't have really a time to go over her blueprint until tomorrow, or to get it uploaded until tomorrow. Anything else? Okay, thank you, students, for doing your presentations. They were excellent, and I guess I'll just see you next Monday. But you're welcome if you see me taping, because I have to tape the review. If you see me doing that, you're welcome to pop in and do that, because I do like to ask questions, but when nobody's there, I just kind of plow through it. So see you then. See you next Monday, and remember, you can text me with any questions. All righty? All righty then. Thanks. Bye.